Hey, good morning, everyone. My name is Suzanne. I'll be presenting on acute coronary syndrome. I'll refer to it as ACS for short today. Per the Mayo Clinic, ACS is a term that describes a range of conditions related to sudden reduced blood flow to the heart. So in short, it can be unstable angina, and STEMI or STEMI. So when we're discussing different types of ACS, I like to use the highway and business analogy. So imagine your coronary artery is a 5-lane highway, right? So the cars represent red blood cells or customers, and the shops are your cardiomyocytes that need these customers to come in so they can stay open. So in a healthy artery like this, blood flows freely and the shops are getting plenty of customers so they're nice and happy. So now let's represent a coronary artery with atherosclerosis. So we've got trash and rubble piling up on the sides and it closes 2 lanes. So the traffic is slowed, but there's enough getting through that the shops aren't really that affected. So this is the pre-existing condition that increases your risk of developing ACS. So let's head down and see what unstable angina looks like. So in this case, the fibrous cap on the plaque has a small tear and the platelets rush in to form a clot. You've still got 2 lanes open, but your business is further down the road from the partial blockage is starting to feel some stress. So, as seen by Homer Simpson, this is a warning of an impending heart attack. And although we still give it, you can't reliably get relief from medications like aspirin or nitro. So it can either spontaneously resolve as the clot begins to dissolve, or worsen into something like NSTEMI or STEMI. So this must be treated as a medical emergency regardless. So we'll pan over here and look at manifestations of unstable angina. So they include an acute onset of chest pressure or heaviness at rest. So this is not predictable like stable angina, where physical activity or stress induces the pain, where it's a demand issue. Unstable angina is a supply issue. So we see what also is a common theme in ACS, which is diaphoresis, nausea, anxiety, and a feeling of impending doom. And a quick side note, I used to think it was silly when textbooks said that phrase, but it is a real thing. So people say stuff like, I'm going to bleeping die, or I'm not going to make it. And it gives me the chills now because they often do go into cardiac arrest and stop breathing after they say it. So people can sense death approaching, so don't ignore or downplay it when people express that feeling. And lastly, our ECG will be negative and troponin will also be negative for now. We'll head down to end STEMI now, where the plaque has fully ruptured. So a thrombus is forming and all but 1 lane is blocked. So shops that are close to the blockage are okay for now, but the shops furthest downstream are beginning to close permanently. So this represents cardiac muscles in the inner layer of the myocardium dying first because it is the furthest from what little blood is coming in. And then the owners pack up in a U-Haul and drive away, representing troponin entering the bloodstream. So we'll look at the manifestations of NSTEMI. They're pretty similar to unstable angina, but more severe. We'll talk about atypical presentations a bit more later. Notably, there is no ST elevation because of the way ischemic current vectors affect the ECG. So for the scope of this presentation, we just need to know that NSTEMI produces ST depression and T wave inversion. Sometimes ECG changes do not appear immediately. That's why serial ECGs are important. As more cardiac cells die, we can start to see ECG changes. You will also have positive troponin. Finally, we'll look at STEMI. So this is a fully or near fully occlusive infarct. So there is no oxygenated blood passing through. This causes injury to the full thickness of the heart wall. Lots of cardiomyocytes die and result in a sharp increase in troponin. So for manifestations, we have severe substernal crushing pain that does not improve, along with pallor and other associated ACS symptoms. We see that classic ST elevation, and our troponin will also be really high. Let's take a look at pre-hospital treatments. So there's 3 main things. First, we do 324 milligrams chewable aspirin as soon as possible. It reduces platelet aggregation and is proven to lower mortality. This is usually the first move. Second, we consider nitroglycerin for ischemic pain, but only if the patient is hemodynamically stable. So in most systems, systolic blood pressure above 90 or 100 is usually required. So it venodilates, reduces preload, and drops oxygen demand as a result. And it also promotes coronary vasodilation. So huge cautions though, hypotensive patients, so like anyone on ED meds like sildenafil or even a right ventricular infarct who's preload dependent, nitro in those settings can tank their pressure, so we want to watch for that. Third, oxygen, but only for hypoxic patients under 91% SpO2. We usually titrate to 94% and then stop. Supplemental oxygen causes vasoconstriction, so we want to give them just enough to where they're oxygenating, but not causing too much vasoconstriction. More is not better in this case. For COPD patients, we usually give them enough oxygen to get to about 88 to 89% to maintain that hypoxic drive. In the hospital, definitive treatment is percutaneous coronary intervention, or PCI. So first, we do an angiography. It kind of gives us a roadmap using contrast dye and x-rays to see exactly where the blockage is. Then in the cath lab, a catheter goes in via the radial or femoral artery, navigates to the occlusion, and places a stent. This is like the highway crew showing up, clearing the debris, laying down a stent, and reopening that lane. Risk factors split into two buckets, things you can change and things you can't. So the modifiable ones are things like smoking, hypertension, diabetes, all the good things. So the unmodifiable factors are being male, older in age, so men over 45 and women over 55, and inherited conditions like familial hypercholesterolemia or familial coronary artery disease. For women specifically, estrogen has a vascular protective effect. So after menopause, right around age 55, that protection disappears, which is why risk climbs steeply. And because women present atypically, ACS is easier to miss in them. Since we are running out of time, we will very briefly touch on atypical presentations. So women, elderly, diabetics, and CKD patients often don't present with classic chest pain. So we can see things like fatigue, nausea, back pain, epigastric pain, and sometimes no chest pain at all. This is how ACS gets missed. So quick summary of what we covered. So ACS is a spectrum. So there's one highway and progressively fewer lanes. Symptoms alone don't diagnose. You need ECG, troponin, and time. Stable angina is demand too high. Unstable is supply too low. NSTEMI kills the inside layer first, then progresses outwards. STEMI kills the whole wall. Treat fast, aspirin, and nitro if appropriate. O2 only if needed. And remember, you need PCI to reopen that road. And always think atypical. That's how ACS can be missed. Thank you very much.